Welcome to our webinar, Giving Control Back to the Patient, CLS and the Return to Physiologic Control. I'm David Hayes, Chief Medical Officer for BIOTRONIK, Inc., and thank you for joining us for the webinar. We're going to hear from two experts in the area discuss the physiologic benefits of CLS, which I refer to as impedance-based myocardial contractility rate adaptation, and why this is especially important as we attempt to optimize physiologic pacing in the current era. We will reserve time for discussion after we hear from both physicians. As questions arise, please type them into the chat and we will prioritize them in the discussion. I want to begin by introducing Dr. Matthew Evans. Dr. Evans is a board-certified cardiac electrophysiologist at Baylor Scott & White and is dedicated to caring for heart rhythm disorders. After he received his MD degree from West Virginia University in Morgantown, Dr. Evans moved to Texas and served his internship and residency in internal medicine at Brooke Army Medical Center in San Antonio. He then served as chief of medicine at Bain Jones Army Community Hospital in Fort Polk, Louisiana. After that, he was deployed to Afghanistan. This is something, Matt, I didn't know about you before, with the 10th Mountain Division, and earned numerous commendations, including the Bronze Star Medal for providing care under direct fire. Upon his return, Dr. Evans completed fellowship training in cardiology and clinical cardiac electrophysiology at Baylor Scott & White Memorial Hospital in Temple. And also, Dr. Evans remains a major in the Army Inactive Ready Reserves. Matt, thanks for your service. He's well-versed in all aspects of heart rhythm disorders. And at this point, I will turn the microphone over to Dr. Evans, who will discuss physiologic pacing from A to V using the autonomic nervous system to restore physiologic rate response. Dr. Evans.
Thank you, Dr. Hayes. That's great. Thank you for that introduction. It's very flattering. And and thank you all as well for allowing me to be here to talk about this. This is something that I'm going to start this out with a little story. I'm not going to take too long, but a year ago, I didn't know what CLS was, and I didn't know who my BIOTRONIK rep was. And we have one of those gurus here in town in Dallas who does, Dr. Levine, who does a lot of work with POTS and orthostatic hypotension patients. And he sent me a referral specifically to put in a BIOTRONIK device with closed loop stimulation. So I said, great, thank you for this consult. I'll absolutely do it. But then that was followed by Googling. And that was then followed by, okay, well, let's try it out. Sure. And so that's how I met my rep, and that's how we got started. And that patient ended up doing phenomenally well. It was life-changing for them. And since then, it's caused me to look more and more in this direction. And this is something that, we talk about, especially within the electrophysiology realm. Pulse field's kind of getting a lot of the glory, and you can pull up the slides. But the really conduction system pacing has been what we've been talking about more and more. Ever since biventricular pacing in particular, we've started to look at how are we going to, especially in the heart failure population, try to mimic normal physiology, a normal pattern of contraction. And I think we're doing very well in the ventricles. But when it comes to the sinus node, we're kind of treating the puppet and ignoring the puppeteer. The sinus node is in a physiologic location relative to where we put the leads. So there's that. But the methods by which we look at patient activity and trying to select what we think is a physiologic range of heart rates for this person based on what activity we think they're doing is kind of archaic. When you're looking at accelerometer or minute ventilation based systems, there's a lot to be desired. And in my clinic in particular, I can tell you that every visit with someone with a device, we would be looking at rate response and constantly adjusting a lot of these patients. And I have yet to do that with the CLS device. And we're going to talk about how they are programmable, how they are customizable to individual patients. But for most people, they're ready to go right out of the box. And instead of using a surrogate of movement or ventilatory effort, we are actually getting direct beat-to-beat measures of actual physiology through the right ventricular lead. And this can be done with any right ventricular lead, and all BIOTRONIK devices, including pacers, ICDs, CRTs, have this. But I just don't think it's very well known about. And if you don't know about it, you can never choose it as an option. So again, I feel like this is something that that I can really speak to at length. Next slide. And so you'll see here just kind of the basics of conduction system pacing. And like I said, it's done a very good job with the ventricles, but we have a little bit further to go if we're really going to pay attention to the puppeteer, so to speak. Next slide. So in order to best provide a physiologic response, we need to be able to tap into that system. The autonomic nervous system, again, I keep using that analogy, but really it's true. The strings of the puppeteer to connecting it to the puppet are sympathetic and parasympathetic tone, causing increases and decreases in heart rate. And that can occur quite rapidly. And many of the available sensors that exist just can't provoke a rapid enough response to changes in physiology in enough patients to where this is something that's truly potentially a game changer. Next slide. So this is kind of going down through a bunch of quotes, just kind of tying that together. We know that heart rate variability, both diurnal and over 24 hours, is associated with health, and a lack thereof is associated with some pretty hard cardiovascular events. I myself measure my heart rate variability, just because I'm a nerd. But the reality is that the closer we can mimic this, I think the better people are going to do. And it's in the data as we're going to go through, as it relates to heart failure, as it relates to AFib, as it relates to neurocardiogenic syncope, as it relates to your elderly patient who has orthostatic hypotension. Next slide. So again, the cardiovascular system, like many systems in the body, are closed loop systems. They're feedback systems. The carotid bulb in particular is constantly measuring the blood pressure and the heart rate going through it. And it then sends a message to the central nervous system saying, should we increase or slow down the heart rate? And by virtue of that, should we increase or decrease contractility? And so being able to interact with this system, to plug into it, so to speak, is going to be very important. And that's what this device really sets out to do. So we're looking for an algorithm that can mimic normal sinus node function, and in particular, the variability that's associated with that. Next slide. So how does CLS work? Well, this is kind of a primer. We're going to get into it in a little bit more of an engineering background, not too deep, but the basics are this. We're really using changes in right ventricular impedance during early systole to kind of give us a surrogate for what contractility is, what both the preload is, and also how hard the heart is working. And these are both things that are typically responsive to autonomic tone. So the device creates this template, so to speak, to create what it thinks is normal for your impedance. And then every beat, it compares those dynamics of the resistance that it's sensing to what it considers its baseline. And then based on that, it decides whether to speed up the heart rate or to start backing back down. Next slide. So properties of the normal sinus node, there's this thing such as intrinsic and extrinsic sinus node dysfunction. Intrinsic sinus node dysfunction is the cells are just faulty, be it fibrosis, be it ischemia. But a lot of cases of sinus node dysfunction are also extrinsic, meaning that the sinus nodal cells are no longer appropriately responding to the cues that the body is sending it through the autonomic nervous system. So again, when we think of rate response, we think of something, does your heart rate increase with exercise? And for accelerometer-based technology, movement does a pretty good job with that. They do a pretty good job at sensing changes with exercise based on movement after several beats, once the device has had time to recognize and adjust to it. Again, going back to the patients that I've had with rate response on in the clinic, very often I'll teach them the hack to tap on their chest to kind of try to activate the rate response if they feel like it's not keeping up with them. And then I think, wow, it's crazy that we're even having this conversation. But they thank me afterward for telling them how to do that. I've never had to say that with one of these devices. But importantly, it's not just the physical stress itself. I have a lot of cyclists. I maybe have too many cyclists as patients. I'm going to be quite honest. And there are very reasons behind that. But the cyclists are difficult because they're not a high movement sport. And especially starting out and sprinting, they have a hard time if they have sinus node dysfunction keeping up with that, which my older endurance cyclists definitely do. So this has more of an ability to sense that from the beginning and start making adjustments as soon as that difference is sensed without necessarily having a movement surrogate. The second thing is that even mental stress can be detected by CLS, and we'll go through that a little bit more. And as we already discussed, heart rate variability, I think, is very important. I think the data bear that out as well. And this is the only system that's able to directly address that. Next slide. So basically, an accelerometer can increase the heart rate with exercise, as can minute ventilation, which is MV. Now, for those of you who are unfamiliar with minute ventilation, basically it's sensing your respiratory rate through thoracic impedance. And so when someone's more active, they'll start breathing heavier. But there's a delay to that, before that happens. It's very easy for us to increase our heart rate 10 or 20 beats a minute without really increasing our ventilatory effort. But that's what most patients need. Most patients need help doing their ADLs. They're not going to go out and play collegiate basketball later that day. They need to be able to sweep the floor. And that's how CLS is really good at picking up on that as soon as it starts and adjusting the heart rate appropriately. Acute mental stress, accelerometer can't see. Minute ventilation can, if it's stressful enough and you start breathing heavy, but CLS can sense that too. And the remainder of them is only something that CLS can really address. Next slide. So the engineering time. I'm not an engineer by trade, but I pretend to be one from time to time. Let's talk resistance. We also call that impedance. What that is the resistance of electricity to get into a tissue at baseline. So it turns out that myocardium is 5 times higher impedance than the blood pool. So the lead at rest, at end diastole, is surrounded by a bunch of blood and the impedance is pretty low. But then once contraction occurs, the myocardium bunches up around the tip of the lead and the increase of impedance is measured. And so this creates kind of a curve of impedance throughout the beginning of systole to kind of tell where the heart muscle contraction is. And so the smaller fraction of myocardium relative to the blood pool, the lower the impedance is going to be. And during contraction, the higher the impedance because you're going to have more heart muscle contacting the lead relative to the blood pool. Now, with increased force of contraction, that impedance curve changes. With decreased preload, where you start out with a lot more myocardium because this person's not getting a lot of blood flow returning to their heart, that impedance is different than the baseline. And the device can see these and respond to it. Next slide. So this is the patient-specific baseline of contractility that's formed through impedance measurement. What the device actually does is through that right ventricular lead, in early systole, it sends several pulses that are subthreshold. They don't capture. But what they do is they're able to spit back an impedance number. And then that number is plugged into this algorithm. The device does have an accelerometer, and all of these devices can be programmed as typical rate response. Never done that, but it can happen. But in this case, what the accelerometer is used for is the patient at rest? And so if the accelerometer has determined this patient seems to be at rest, I'm going to go ahead and save a template. And it delivers several pulses and creates this baseline waveform. Then it does it again and again and again. And I believe it takes 256 samples to build its composite of what it thinks your baseline resistance is, and updates this about once a week. So again, it's person to person. It's very personalized, and it changes with the patient. So this is the reference waveform, and this is what it's going to compare the resistance of every subsequent beat against. And next slide. And so this is kind of what we see with light loads, the difference between the rest impedance curve in the black and the gray impedance curve. And next slide. And here you can see more vigorous contraction. You can see how the curves are separating significantly. The decreased preload comes in, the increased blood flow, the impedance goes down. The contraction becomes very vigorous, the impedance shoots back up. Next slide. And then under high load, you can see it even more exaggerated. And the device can respond to this in a dose-dependent manner. And then when this starts to regress back toward the baseline, the device can respond to that in a dose-dependent manner. Next slide. And here you see, the more the difference, the more the differential, the faster the pacing. Next slide. So CLS is able to deliver beat by beat response and also a gradual decrease based on what it's sensing. Are you ready yet to start backing down the rate? And this is a great slide. So you can see on the top that there's CLS, and on the bottom there's an accelerometer, and you have a series of tests. First is hand grip. And you can see the accelerometer actually responds fairly well. And then rest, it goes back down. And then you have mental stress, nothing. Meanwhile, the CLS is responding, not as vigorous as it did with hand grip, but it's still able to sense that and respond. And then drug, meaning isoprel. So an isoprel would be administered. And look how well the CLS is able to track that. And meanwhile, there is a little bump in the accelerometer, and that's interesting because it's not a minute ventilation sensor that it says. So I'm thinking maybe they're just sensing that maybe the patient's not sedated and kind of wiggling around as patients do on isoprel. But you can still see a massive difference in these responses. And that's because CLS doesn't require movement to sense changes in physiology. Next slide. So the PROVIDE trial showed really improved. The chronotropic incompetence is really where it's at when it starts with these devices. High energy activity, peak VO2 increased by about 20% in that study, which is, to increase peak VO2 that high is just incredible. Improved quality of life in greater than 97% of patients, those expressing a preference for CLS. And even low energy activities of daily living, which honestly is really where most of our patients need it. Walking, sweeping, standing. In comparison with rate response, patients did better in the CLEAR study. Heart failure, I'm going to leave to Dr. Sue to a large extent, but there are two big points that I just want to hit home real quick. And that is that really in those patients whose EF improve after device implantation with CRT, those patients did really well. And again, this gets to what is this going to do with conduction system pacing? If you're able to combine those two together, I think this is extremely compelling. Another thing too is that upon standing, the decrease in preload again leads to that relative change in the impedance curve, and the device can react. So as I alluded to earlier, I have a lot of sinus node dysfunction and orthostatic hypotension coexist in a lot of patients. And it's often hard for me to argue against putting one of these devices in, because if they even give me a hint of they're getting dizzy when they stand up, it's hard to piece that apart. Is that the heart rate? Is that the chronotropic incompetence? Or is that a blood pressure? Is that a preload problem? And this kind of hits all of those from the beginning. So a lot of my elderly patients end up getting this device. And then going back to heart failure, they actually looked at people who had CLS devices in heart failure and showed that their EF had improved on follow-up. And that's going to be just a little teaser for Dr. Sue's talk. I think he's going to cover some of that. Next slide. So again, CLS produced better physiologic heart rate, improvement 6-minute walk test, and improved quality of life and well-being. Next slide. Other unique benefits of CLS, and I wish I could talk about this for another half an hour because this is really interesting. There's a reduction in device-detected AFib. We're going to hopefully have time to talk about the burden studies. Reduced episodes of symptoms of vasovagal syncope, and I think that you can kind of imagine how that would be the case because that's largely a preload problem. And if we're able to overcome that, at least in part with pacing, that's a big deal. Improved ejection fraction and improved quality of life. Next slide. So this starts to go over burden 3, but I'm really quickly going to go over burden 1 and 2. Burden 1 was the first kind of trial of, can we make a difference with device-detected AFib? They had 149 patients with tachybrady syndrome who needed a dual chamber pacemaker, and they had to have had one or more documented episode of AFib in the prior 6 months. They were randomized to 3 pacing modes. So this was randomization across the group: CLS, accelerometer, or overdrive pacing. Over a 7-month follow-up, CLS was associated with a significantly decreased rate of device-detected AFib compared to the other pacing strategies. And across all these studies, overdrive pacing did the worst. And that's important because one of the things that's been discovered through these studies is that these all involve more atrial pacing in the CLS group, but it was probably more effective physiologic atrial pacing than just blanket overdrive pacing, which is not physiologic. Burden 2 was a randomized crossover design, larger cohort, 451 patients, and each patient got 3 months of CLS, 3 months of DDDR, and 3 months of overdrive pacing in random order. So it was the same patient comparing the results. And there was a 15% reduction in device-detected AFib compared to overdrive pacing and 6 to 7% reduction compared to typical accelerometer-based rate response. So this then led to Burden 3, the big study. And it is really tough with these studies to adjudicate device-detected AFib. And so Burden 3 worked really hard with that. Next slide. And so the primary objective was to compare CLS to typical rate response, and also other endpoints such as subclinical AFib, stroke, TIA, and that's over a 3-year follow-up. And again, subclinical AFib was defined by an atrial high rate event greater than or equal to 6 minutes, and that's been linked across studies to be associated with more hard endpoints of major adverse cardiovascular events and true AFib. So of course you were excluded if you had permanent AFib, because obviously you're going to have AFib at that point, advanced heart failure, dialysis, an indication for CRT, or if you'd had CLS by accident prior to. So next slide. So this is the general design and fallout of the study. I'm going to keep moving in interest of time. Next slide. And this is the money. So this is what we saw. Overall, there's a 16% relative risk reduction of device-detected AFib with CLS compared to DDDR pacing. And the difference was driven by fewer episodes with a duration between 6 hours and 7 days. So the big, long AFib episodes were the ones that were really impacted. And the effect was greatest in patients without AV block. So if you take out the AV block patients, you're talking about a 23% relative risk reduction. And in patients without a history of AFib, 27%. Next slide. And this is just, and this can be looked at on your own. That's kind of what I already talked about with the AV block and the AFib history as well. Next slide. So why no AV block? This is very interesting because it's thought that the RV pacing burden in that study might have been an opposing negative impact. And there's also the questionable benefit of conduction system pacing and preventing pacing-induced cardiomyopathy. But again, then you wonder what would happen if you combine CLS with conduction system pacing. And it seems like that might overcome that deficiency that was seen in the AV block population because you would keep it physiologic during that time. But again, the percentage of atrial pacing was consistently higher with CLS than DDDR in all these studies. But again, we know that just overdrive pacing isn't what it is. And so it's thought that CLS can track and respond to carotid stimulation and baroreflex activation. And next slide, I think that's on there. No, I think I'm missing that slide. But CLS can actually track and respond to carotid stimulation and baroreflex activation. Also, a lower heart rate variability is associated with an increased risk of AFib. We know that from several sources. So restoring physiologic heart rate variability may play a role in AFib prevention. And a suboptimal recovery from heart rate variability through cardiac pacing may have negative implications for patients with sinus node dysfunction. So this is kind of the general slide for what we're looking at for closed loop stimulation. Obviously, sinus bradycardia and chronotropic incompetence, it can go very far to restoring normal physiology and interacting with the puppeteer and dancing with it instead of dancing your own dance, which is kind of what accelerometers do, and not infrequently. There's the potential for decrease in AFib, and being someone who treats a lot of AFib and having a lot of AFib in my family, this is very important to me. If we can actually get ahead of it and try to correct some of that autonomic derangement that happens, we know that happens early in the course of AFib, then this might prevent a lot of stroke and a lot of morbidity. So I'm going to leave it at that. And thank you all so much for your attention. I'm happy to entertain any questions. And like I said, I could go on for an hour. So by all means, let me know.
Matt, thanks. Great talk. And I think you've really done a nice job explaining the physiology behind CLS and the incredibly important connection to the autonomic nervous system. We're going to hear more about the connection to the autonomic nervous system from our second speaker, Dr. Jonathan Su. Dr. Su is a board-certified cardiac electrophysiologist and professor of medicine at UC San Diego Health. He's also a clinical research investigator with advanced training, and his interests include epidemiology and clinical outcomes in patients with all types of cardiac arrhythmias. His research has resulted in publications in the New England Journal of Medicine, as well as other key journals such as JACC and Circulation. He earned his medical degree from Northwestern University Feinberg School of Medicine, then completed a residency in internal medicine at Mass General, and fellowship training in general cardiology and advanced subspecialty training in EP at UCSF School of Medicine, where he also obtained a master's degree in clinical research. He's board certified in internal medicine, cardiovascular disease, and cardiac electrophysiology. Dr. Su will address ANS-driven physiologic pacing, benefits, and consideration for heart failure patients. Dr. Su.
Thank you so much, Dr. Hayes, and to BIOTRONIK for this opportunity to talk to you all in regards to CLS and relation to the autonomic nervous system. You had a wonderful talk by Dr. Evans in regards to background and some physiology. Pardon me for some overlap in regards to hammering some of those points home because our group at UC San Diego and I personally have found this to be instrumental in use in our patients in getting pacing, and to the point where we obviously want to add to the literature in regards to research backing this technology up. If one could go ahead and show my slides, we'd be happy to take things from here. I've been tasked with adding on to Dr. Evans' wonderful talk and want to really focus on the major key population I'll be talking about, which is the benefits and considerations of this technology in heart failure patients. But I also want to talk about atrial fibrillation and its relation to heart failure. So you're going to hear me discuss as a cardiac electrophysiologist to the cardiology community and those EPs in the audience. Thank you for your time. Two key disease processes that we take care of in its relation to this autonomic nervous system and physiologic pacing. So allow me an opportunity to hammer home the fact that chronotropic incompetence is very prevalent in this patient population that we see, which is those with advanced heart failure, particularly those with systolic heart failure. More than 70% of advanced systolic heart failure patients have chronotropic incompetence, regardless or irregardless of beta blocker use. So this is associated, CI is associated with mortality. And we know that heart failure patients really need an appropriate increase in heart rate as per that equation of cardiac output in regards to stroke volume and heart rate equaling cardiac output, right? So we know that this is important, that a high prevalent disease of chronotropic incompetence in heart failure patients could have adverse outcomes. And perhaps correcting this in such a prevalent condition in a heart failure population can lead to good outcomes or better outcomes. In those patients with improved ejection fraction, improvement in chronotropic incompetence can really benefit patients with heart failure from CLS, because we know CI is a predictor of CRT non-responders for patients in sinus rhythm. And if you look at Dr. Prof investigation looking at CLS with heart failure with improved ejection fraction patients with severe CI, they did this wonderfully thoughtful clinical trial design where they did a randomized crossover multi-center trial randomizing patients to DDD CLS or DDD 40 for 1 month, and then patients were crossed over to DDD 40 or DDD CLS respectively. They enrolled patients, obviously, with BIOTRONIK CRT devices that had the CLS function with class 1 indications of at least 6 months before enrollment, had stable heart failure status, as you would expect in the NYHA class 2 or 3 heart failure range to be indicated for a device. And the primary endpoint was change in ventilatory efficiency, or the VE slope, during cardiopulmonary exercise testing. And what you see in the graph on the right is that when patients were crossed over, what was seen was that the VE slope was improved by about 4% for CLS versus just regular DDD pacing. And about 1/2 of patients were responders to CLS, experiencing at least a 5% improvement. CLS responders saw a VE slope improvement of about 16%, and that could translate to about a 70% lower relative risk of major cardiac events. And data suggests that CLS may provide the greatest benefit for CRT in patients with less advanced heart failure and severe, specifically severe chronotropic incompetence. So our group, and we've always been interested in CLS, particularly in a heart failure population. And we wanted to add to the heart failure literature in regards to CLS. And we devised this class trial, we called it, basically comparing rate response with CLS versus accelerometer in patients with ICDs in a heart failure population with BIOTRONIK CRTDs. Now, we chose this population to really try to standardize the patient population we were looking at and really try to tease out a potential difference with CLS versus accelerometer. So as you can imagine, these individuals would have an indication for CRTD and therefore have a low ejection fraction in the standard indications for CRT and with a defibrillator, and therefore potentially even things out in regards to the patient population that we were looking at. And we wanted to look at the effect of CLS on functional capacity. True, what your patient cares about, your heart failure patient cares about, as well as how they can do, how well they are in quality of life, particularly those with heart failure with reduced ejection fraction. We devised a trial design that was randomized. It was blinded, and it was a crossover design trial as well with these bio-CRTDs. We looked at 6-minute walk tests, cardiopulmonary exercise testing, follow two specific one week periods of 1 week of CLS on, and the patient was crossed over to accelerometer on in different orders for different patients. And what we saw in this study, the class trial, was that there was a trend towards improved quality of life as measured by the RAND-36 score, with significant improvement in emotional health, specifically with CLS. That p-value was 0.06. And that's why we say it was a trend. It didn't meet statistical significance. Of note, we did not notice any true quantitative metric differences in regards to 6-minute walk tests or peak heart rate specifically. But this quality of life metric that we saw in our class trial, we think is important for your patients that have these devices or have an indication for device and their subjective improvement in how they feel. I want to talk a little bit about an epidemic arrhythmia and condition that we treat as electrophysiologists and cardiologists, which is really subclinical atrial fibrillation or atrial fibrillation in general, and its overlap with heart failure with preserved ejection fraction and its impact on functional capacity. For those of us that follow devices, subclinical atrial fibrillation is very common and can be a significant risk factor for adverse events in patients with heart failure. In fact, Yang et al. Found that in patients with HFpEF, patients with atrial fibrillation had greater dyspnea, reduced exercise tolerance with atrial fibrillation, and were only able to walk shorter distances on 6-minute walk tests and reported more exertional symptoms compared to patients without atrial fibrillation. And what was found by others is that even short episodes of subclinical atrial fibrillation have been associated with increased risk of adverse events from atrial fibrillation itself or heart failure with preserved ejection fraction, including stroke and systemic embolism. Here's a slide and a graph that really talks about the conundrum that we have with both of these disease processes that I've highlighted, which is heart failure and atrial fibrillation. We know that it is a chicken and egg type situation where one seems to cause the other, and there's a feedback loop that the other causes the one. And therefore, talking about each of them and their shared causes and effects are really important when we think about pacing in our patient populations. We know that atrial fibrillation worsens heart failure, and we know that heart failure begets atrial fibrillation. If you look at the graph on the right, we can start talking about some of the mechanisms for that. If we start first with the blue area with heart failure, how does heart failure get over to the right with atrial fibrillation? There can be some cellular calcium dysregulation and disorder of the RAS system, fibrosis from the heart failure causing left atrial stretch, conduction slowing from the heart failure itself, and the potential that has been shown in studies to actually increase the amount of triggers and pulmonary vein ectopy, therefore inducing atrial fibrillation, whether it be by stretch mechanism or otherwise. Now, atrial fibrillation coming around up and around the wheel from red to blue, with the atrial fibrillation on the right to the red. We know that a rapid, irregular rate can not only cause loss of atrial systole, but decrease cardiac output and cause ventricular dysfunction by that mechanism itself. And then the rate itself, in regards to tachycardia-mediated cardiomyopathy, can cause heart failure or reduce ejection fraction in and of itself. And then the wheel spins around and causes more atrial fibrillation. We'll get back a little bit to heart failure and atrial fibrillation and bring everything home, but I wanted to highlight this study by Sims et al. Looking at the VO2 max in heart failure patients and how it can be potentially optimized with an appropriate pacing rate. What they found was that there was a 20% increase in VO2 max that could be achieved with appropriate rate adaptive pacing. So just trying to improve with rate response those patients with heart failure if they had severe chronotropic incompetence with less than 70%. So the oxygen consumption in CI patients was improved in those patients who had gotten some type of rate responsive pacing in a CRT population. So if you look at potential CLS benefits for heart failure patients in general, this slide really tries to sum up what we talk to our patients about or we think about in regards to chronotropic incompetence and heart failure. We know it's common in systolic heart failure patients. We know that chronotropic incompetence is associated with increased morbidity and mortality in cardiac events. And we know that exercise, which is obviously involved in increasing the heart rate, is a class 1 AHA guideline recommendation for heart failure patients. And we tell our patients that exercise is good and can reduce mortality and heart failure hospitalization. So studies show that CLS provides an appropriate rate response similar to patients with healthy sinus nodes, and therefore could be quite beneficial to our elderly and frail heart failure patients, mostly who may be participating in quite low movement or low energy activities. So when we think about the potential CLS benefits for heart failure patients, I think we need to think about a control group of those patients that may not need pacing. And when we compare it to an accelerometer group, these are the type of patients perhaps that we want to think about. So there is the potential for CLS to benefit our heart failure patients by providing significantly wider heart rate distribution or heart rate variability. And accelerometer was found in the study to the right to have significantly lower heart rate variability than both control groups and CLS, as you can see with the lower bar graph to the right if one uses accelerometer. And the CLS group appeared to be quite similar to a control group. Again, coming back to autonomic dysfunction in heart rate variability, we know that SDNN, or a metric for heart rate variability, is really important in a heart failure population. The lack of heart rate variability is associated with autonomic dysfunction, which can be quantified by measuring heart rate variability. And a reduction in heart rate variability identifies patients who have a high risk of death and is quite a profound predictor of death due to progressive heart failure and other clinical measurements in our heart failure population. So heart rate variability is important to heart failure. How should one think about CLS and pacing in a heart failure population, which includes heart failure with reduced ejection fraction and heart failure with preserved ejection fraction? Well, if one could start in the middle at the top box, the top blue box in the middle, and then if you're facing the screen, go to the right. In any patient who has indication for or evidence of chronotropic incompetence or symptomatic sinus bradycardia, remember that's obviously an indication for pacing, then one does need to think about a CLS implementation in that cohort due to the fact of the data that Dr. Evans and I perhaps presented. In a regular heart failure with reduced ejection fraction and HFpEF population, if one goes straight down to a workup of etiology and looking at regular therapies for these patient populations, which include medical therapy with goal-directed medical therapy, if one goes to the left and has an EF improved, then perhaps one can just rely on goal-directed medical therapy and only an ICD if the EF drops below 35%. But if one goes to the right and with the yellow box where EF is less than 35%, one does need to think about ICD therapy and consider CCM. But again, in this general population, if one does a workup and finds chronotropic incompetence, sinus bradycardia, or other symptoms of heart failure and has this indication, I think one does need to consider CLS implementation as one goes straight down to the bottom blue box. And again, coming back to atrial fibrillation and its relation to heart failure and CLS, the Burden 3 trial, which Dr. Evans talked about, showed this significant reduction in the composite endpoint of subclinical AF in the CLS compared to accelerometer. So if we're thinking about atrial fibrillation in our patients, and I think we all are thinking about atrial fibrillation in all our patients, including those with heart failure or devices, this lower risk of atrial fibrillation incidence is really important, but really profoundly seen even more significantly in those without a need or a history of AV block, perhaps less need for ventricular pacing, and perhaps even more profound in those with no history of atrial fibrillation as well, as seen in this Burden 3 study. So if we think about the mechanisms of CLS and how it may reduce atrial fibrillation, again, CLS can help stabilize the autonomic tone, and therefore we know with data coming out that sympathetic surges can be associated with the risk of atrial fibrillation. So by improving autonomic imbalance, perhaps we can reduce atrial fibrillation episodes and atrial fibrillation burden. Number 2 there, in regards to rate stabilization and reduction of bradycardia, what I talk about is basically, we know that depolarization affects repolarization, and AFib can occur in patients with sinus node dysfunction and bradycardia, and with slowing of the heart rate, atrial ectopy, and what I call torsades of the atrium can occur and be and cause for a chaotic rhythm, particularly with bradycardia. So maintaining not only a normal rate, but a more physiologic rate, we physiologically think can reduce the risk of atrial fibrillation. And then third there is improving hemodynamics, particularly in a heart failure population, by reducing cardiac output and metabolic demand. Perhaps atrial stretch is improved and therefore atrial remodeling and a reduced risk of atrial fibrillation, allowing us to not spin that wheel around in regards to heart failure causing atrial fibrillation and atrial fibrillation causing heart failure. So in summary, unlike rate adaptive pacing with accelerometer, CLS truly assesses myocardial contractility changes on an almost beat, very time-sensitive manner, as Dr. Evans elucidated, and therefore allows us to adapt the rate in regards to physiologic demand for the patient. We also think that CLS gives the patient its own like autonomic nervous system control of the heart rate, and that it may be CLS, that being, may be particularly advantageous in patients with heart failure in need of CRT, as we studied in patients with CRTDs in regards to improvement in quality of life, but also other metrics, including subclinical AF and cardiopulmonary exercise testing parameters such as VE slope, particularly in heart failure with preserved ejection fraction patients. Thank you very much for your time and attention.
Thanks very much, John. That really a great overview. And, the evidence base in CLS is broad at this point, but the evidence base on CLS and heart failure is really pretty limited. And you did a beautiful job going over the information that exists, you having contributed to that. I want to start with one. We can go ahead and bring Dr. Evans on the screen as well. But Jonathan, as long as we're on that, I want to start with a question. In your last slide, after summarizing this, you said there's the potential. What do we need next? Do we need a large-scale trial looking at CLS and heart failure? And you know how difficult these are to do. Is it possible we could get that information from real-world data, like from home monitoring? What are your thoughts about taking it to the next level?
Yeah, Dr. Hayes, you know as well as everyone that these are really hard endpoints to study. The power we need to detect some of the outcomes that we are looking at require sometimes thousands of patients. So I do think, particularly with BIOTRONIK's vast amount of information with remote monitoring, and its ability to have quite real-time type home monitoring. I think we can look at some of these outcomes, particularly if we link to large administrative databases like Medicare or other databases. But specifically with heart failure and atrial fibrillation, I do think it's going to require at least administrative databases and remote monitoring in order to answer some of those questions. Now, who wouldn't want a randomized clinical trial with thousands of patients in all these studies? I'm not sure we're going to get there and to answer all the clinical questions, but I do think it would be reasonable to select some of these questions that could be theoretically answered with smaller scale randomized controlled trials, for example.
Thanks very much. I've got several questions I want to get to. And before the first one, I also wanted to say, Matt, I was going to say this in between and forgot to say it. I think it's very telling. Clearly, you now have great expertise with this rate adaptive sensor, but I think it's very telling that this is all because of a referral that wanted the device, and you said the patient then had a life-changing experience as a result. So I think that says a lot about the technology and now how you have really embraced this. And I'm going to come back to that with a question in a minute, but let me start with one, and I'm reading this so that I get it right. Great question. Given the ability of CLS to learn each patient's unique rate modulation needs, is it reasonable to program the base rate from the typical base rate of 60 beats per minute to a lower rate like 50 beats per minute to allow CLS to more closely match lower natural circadian rhythm heart rates at night? Either of you, what do you think?
Well, Jonathan, if you don't mind, that's a great question. I love where the person asking this question is thinking, because they're thinking physiology. They're thinking, how much do we really need to intervene? And I tell you, I do that frequently. It depends on the indication of why I'm putting the device in. But yeah, not only that, the CLS is programmable. There are several facets of it that you can program. One's called RRC, which is the relative rate control, which is how fast the device can go in response to your activity. And particularly in neurocardiogenic syncope patients, the ones that are very young that have the cardioinhibitory, they need fast, aggressive response to drops in their blood pressure, their impedance. Increased impedance. So those patients, you actually would probably program that off to allow them to explode with that to match their physiology. And the same way, I think that setting a lower rate limit lower, especially in younger, healthier patients, to try to match let them take over most of the time is a pretty good idea.
John, any other thoughts on that?
No, I agree with Dr. Evans. I think it's actually a brilliant question to think about the physiology and whether we need 60 as a base rate, and therefore that being the magic number of where it shouldn't go below, because we do know that range, whether at night or at other times for certain people, probably is normal and is potentially better. I don't program that very often, but certainly in patients that want it to be more physiologic or ask about it, I have no problem, and I have programmed it at lower rates with rate response on in the past.
Thank you both. Let me ask this. I think this is a very fair question that came in. Again, Matt, you started this because a referring physician says that's what I want. And John, in your practice at UCSD, I don't know if you get specific referrals like that or not. But the question is, how do we politely question an implanter or refer and guide towards CLS when they routinely choose an atrial leadless device in chronotropically incompetent patients? Is there a way to handle that? Any thoughts?
That's a tricky question.
I was just going to say, there's a tricky one.
So I would say that the shortest answer, and I say this a lot, is that when I started out in private practice, I had the mentality of no one's going to refer to me if they don't know me. No one's going to refer to me if they don't have my phone number. And it's the kind of the same concept of, do they even know this exists? And, can you find a good patient to run by them and say, hey, I've got this guy. I've heard about CLS. What do you think? And I think that's the best way to open the door. I think it's Andrew Carnegie's book, How to Make Friends and Influence People, said, make them think it's their idea and they'll be more likely to accept it. That's my own thought on it.
Very good.
But to follow up on that, Dr. Hayes, and to Dr. Evans, I think, one way to approach that, if I may assume that the person asking the question perhaps is a referrer, or somebody that is in the field that wants to know how to balance that. I think, being aware of chronotropic incompetence, and that it's common, and in some patients, perhaps a device company that only offers accelerometer may be okay in certain patients, but not all patients. And if we detect as people that refer to us that they understand this and say are okay with any device company for this patient, but are specific in other circumstances, and then we really know that referring knows what they're talking about. And specific with things like vasovagal syncope, where CLS, I think personally, compared to the other 3 device companies, is a clear winner. If it's clear that one asks for, if you give examples in other patients where perhaps accelerometer would do fine, I think we would be aware that referring individual really knows when they want a certain capability of a device.
Very well said. Thank you both. Another question that came in is, does CLS improve heart rate variability, and has it been shown in clinical studies?
I believe the answer to both those questions is yes.
Yes.
And I'm trying to remember the name. There have been more than one study, and David, you may be better at answering this than either of us, but Jonathan, you can
in regards to heart rate variability and SDN,
Yeah.
and certainly several studies looking at the fact that heart rate variability is better with CLS, no doubt.
Yeah, and there's I think at least 4 studies, all fairly small cohorts. Certainly, if whoever asked that question wants to, put their name in the chat, we can get specific information to you with those citations. But happy to do that. Let's see. There's another question here. Well, I think what they're asking is, it's a DX-CRT versus the need for CLS and atrial lead. Which is that something that you think there's a preference in a patient, one over the other? Putting in a DX so that you don't have to put in the atrial lead if there's no need for atrial pacing, versus putting in an atrial lead so you have access to CLS.
Yeah, I'll take that one first, if you don't mind, Dr. Evans. But basically, I think we have to make that decision up front. Sometimes we have data in regards to event monitoring and other things to help us, or chronotropic incompetence in regards to a treadmill test, to help us make that decision. The short answer from my perspective with that is, in a patient population where one is likely going to be just tracking the atrial activity and pacing based off that, then obviously the DX lead seems to be a right recipe for that particular patient if one doesn't need the atrial pacing at all. And then in a different population where CI perhaps could exist or does exist, then a different type of device with an atrial lead would be better served in that patient. And I think to kudos to BIOTRONIK for having all that available based on the patient characteristics.
And just to throw my 2 cents in, I would err on the side of dual chamber in that patient, and I'll tell you why. A lot of these patients, especially the more advanced heart failure, you have them on a lot of medications that derange the normal autonomic tone and the normal autonomic nervous system. And we end up with a lot of low blood pressure, orthostatic hypotension in that population that could potentially be served by this. So, in my own practice, I reserve the DX leads for someone, who is maybe a secondary prevention or doesn't really require any atrial pacing that I can see, and can't, and they're doing otherwise okay. But for the patients who have heart failure and have quite symptomatic heart failure but don't meet criteria for CRT, even if they do, that would be the patient that I would say, let's put the lead in from the beginning. There's little to be lost, and we gain a lot of functionality if we need it. And we know that patients with heart failure do well with CLS. So I would err on the side of yes. I don't think that the risk of right atrial lead placement outweighs the potential benefit in heart failure patients.
Yeah, you both make some really great points. Thanks.
May I add something to that,
Sure.
Dr. Hayes?
Yeah.
To Dr. Evans' point, we did a study. We're a center, specifically in our own center. We did a study that honestly defers to basically a dual chamber ICD instead of a single chamber ICD, and the majority of our patients, for not great data supported reasons, including discrimination of ventricular arrhythmias and the potential need for pacing. So I'll be in full caveat of that. And we all know the data in regards to a theoretic higher risk of adverse events in implanting another lead. Any additional lead has its risk of additional complications. That being said, to Dr. Evans' point, we found up to 27% use of rate adaptive pacing in a population perhaps that wasn't thought to need it in 1 year follow-up, suggesting that, to his point, exactly the point that it may be an unexpected use of atrial pacing, but something to think about.
Yeah, no, that's great information. We probably have time for one, maybe two more questions, but you both went over multiple areas where CLS has been shown to be superior to other rate adaptive sensors. Now, we know it works the best for neurocardiogenic syncope, and I think it's long been somewhat pigeonholed, unfortunately, for that indication. But you both talked about the B3 study. What do you think is the biggest potential clinical gains when it's used for sinus node dysfunction and potentially the long-term reduction in occurrence of atrial fib? What do you think about the most important indications?
Yeah, so I'll say from my own end, I mean, we know that sinus node dysfunction and AFib coexist in about 50% or more of patients. I think the range is 40 to 70%. So from my standpoint, and I think that we're going to continue to do more studies looking at device detected AFib. I think that's one of those things that no one talks about, but is massively important. Is we know AFib is a progressive condition, and we know it is largely created and or modified by autonomic derangement. So I think that that in that population, in general, and patients who I think are at reasonable risk for AFib, or we all get these external monitors that show these brief episodes of ATAC, is it AFib? But as those risk factors start to collect, I err on the side of active, putting a CLS device in them as well.
Thank you. Well, we are at the top of the hour. We do have a few more questions, but unfortunately are out of time. Thank you both for your talks. They were both terrific, and I think really covered what we wanted to in terms of, as we're at a time when we're talking constantly about physiologic pacing, which has largely been limited to hardware and where that hardware is placed. To think about this algorithm, this software application to improve physiology is really timely. So thank you both very much. For those of you that have been on the webinar, thank you for attending. This recording will be eventually available, and happy to share it with you. Thank you all.